ready? You got me running.
I am Meredith Hirsch, and this is Working Healthcare. My friend and tireless advocacy champion dropped by the studio while he was in town for a meeting, and you are in for a treat. I've known Dr. Robert Levin, I call him Bob, he's my friend, for about a decade. He's an independent rheumatologist in Clearwater, Florida, and employs about 25 people. And he still somehow seems to juggle running a busy medical practice and the energy to dive deep into the world of advocacy. Bob has a simple but powerful belief. If you take care of patients, you take care of doctors. And if you take care of doctors, you take care of patients. And that's what drives him. In this episode, we dive into pharmacy benefit managers. And if you've never heard of them, think of PBMs as the mafia of the insurance industry. They sit in the shadows, pulling strings and decide which drugs patients actually get and how much you pay for those drugs. Bob and I break down who they are, how they operate, and why you should care about it. We also talk about the Alliance for Transparent and Affordable Prescriptions and what keeps him getting on planes several times a year to go to state capitals and Washington, D.C. He's in front of lawmakers over and over, explaining to them how our healthcare system is working and how we can improve our healthcare system. So grab a seat, listen in, and hear why Bob refuses to sit on the sidelines. Dr. Robert Levin, welcome to Working Healthcare.
Well, thank you, Meredith. It's great to be here, and I look forward to this conversation and working with you in Tallahassee next week.
I know, very exciting with the Florida Society of Rheumatology. I think that people listening to this podcast, if they don't know your name, they're not in the world of rheumatology. You have worked in the rheumatology sphere for so many years. You have an independent practice in Clearwater, Florida. You were the OGs, the creator of ATAP, which is what we're going to talk about as well. And you've been very involved. You're a former president of the Florida Society of Rheumatology, and you sit on 1.5 million boards, or you have at one point. So your name is definitely known. And talking about names, you know my family's Levin.
No, I didn't know that.
Really? I remember.
I think we've had that conversation, actually.
Because I remember when I met you, I said, is it Levin or Levin? And you said, I'm from Philadelphia. It's Levin. I said, yes, my grandmother is from Philadelphia also. Therefore, it's Levin.
That's unbelievable.
I know. So we're teaching everybody listening to the podcast the proper pronunciation. If it's Philadelphia, it's Levin. If it's not, which was one of my bridesmaids, Michelle Levin, but she's from Jacksonville. So no Levin.
Yeah, Levin's more New York.
Yeah.
and that area.
Yes, but my grandmother's very proud of being a Levin. So you are out on the East Coast right now. This is fun that it's in person. We didn't have to do this virtually. We scheduled it forever ago when we were at the meeting at the Coalition of State Rheumatology Organizations, and you're on their board. Why are you so passionate about your advocacy involvement?
Yeah, it's something that later in my career, I really became aware that physicians in general, and especially in our field, which is rheumatology, were being taken advantage of by non-physicians. And the most important thing was that, I guess, the thing that really struck me was that probably in the early mid-2010s, 2015, we were all of a sudden having real trouble getting our patients treated. The whole thing about the whole raison d'etre really is access to care.
Why do you think that there was a pivot in 2010 and that timeline regarding treatment for patients?
You know, starting at around in rheumatology with the advent of advanced therapies, biologic treatments, injectables that were targeted therapies to treat rheumatoid arthritis. The first one was released on the market in 1999. And then, and I remember that. And I remember the pre-biologic era. I'm old enough to have been in practice for a decade before the biologic era actually started. And it was like unbelievable what we could do for our patients. We could take these patients who were absolutely devastated by rheumatoid arthritis, and we had them out of the wheelchairs and up functioning like normal human beings. We were taking them off the disability rolls and putting them back to work. It was unbelievable what we could do with our new therapies.
My dad has psoriatic arthritis, and he's been plagued with psoriasis all over probably 80% of his body my entire childhood. And I remember when we would go to the beach because the salt water and the sun helped dry it out, people looked at him like he had leprosy. And he was definitely self-conscious about it. I don't think I really understood the pain he was in. He kept wanting to say, let's go do some road work. That meant running. I don't know how great that is for someone with psoriatic arthritis, but whatever. We would go to the beach, and that's how he actually treated himself, with a bunch of Advil as well. And so fast forward to what you're saying, 1999, he started using Enbrel when Enbrel came out, and he was one of the original users for Enbrel because he also flew, and so it was the first drug approved by the FAA so that he could fly, and it changed his life. Miraculous.
And we've seen that over and over again, that fast forward to 2025, there have been so many amazing scientific discoveries that have absolutely changed the lives of my patients for the better. These patients are doing great. And, you know, we used to be able to look across the room and tell who had rheumatoid arthritis by all the damage and deformities that were present in their hands and other joints, and the other rheumatic diseases would be very similar. You look now, and these patients who are treated, you can't tell them from somebody who's 100% healthy who's not on these treatments. It's unbelievable. But the drugs at the beginning were considered expensive. Now, fast forward from 1999 to 2025, the list price of these drugs has gone up astronomically, and we can talk about why that's happened.
I want to talk about why that's happened because we're looking at the most favored nation pricing, and that has been talked about with Trump and with his administration. There's also been talk about the top 10 most expensive drugs and decreasing that, and the government negotiating pricing, and Enbrel's on that list actually. And so that may go bye-bye and off formulary for a lot of patients. Why has the cost increased so substantially as opposed to decreasing over time when there are more options available to patients?
So the obvious knee-jerk answer is the greedy pharmaceutical industry has raised prices to increase profits. And that is probably part of the answer.
So you're blaming the manufacturers of these drugs.
A lot of folks blame the manufacturers. I don't have that feeling. I feel that the manufacturers have part of the blame, but certainly not all the blame.
Who's really to blame?
The majority of the blame goes to the middlemen. And the middlemen are called pharmacy benefit managers. And they basically just manage the distribution, the approval, who can get the drugs, basically making medical decisions.
And who owns these PBMs?
The PBMs are owned either by major insurance companies, or conversely, the PBMs are so big that they actually own the insurance companies. But they're basically now, in terms of the mergers and acquisitions that have occurred in this industry, they're one and the same.
Why is there even a need for a pharmacy benefit manager? How did this start?
So it started probably back in the 1980s. And what was going on was insurance companies were starting to cover medications and outpatient services. And so they were formed basically to distribute medications so that they could properly account for and distribute medications. This is way before the biologic era.
Who paid them at that time?
The insurance companies.
So they were actually a part of the insurance company doing a favor, or I guess providing a service for the insurance company, like our medical practices. If we hire someone to answer the phones at the front desk, they're providing a service. So we obviously have to pay for that. So the insurance company would take their deductibles, the premiums that patients are paying, and utilize that money to be able to hire or outsource, or not even outsource, utilize these pharmacy benefit managers.
So they were independent companies.
Okay.
And so they would be hired. Now, actually, some of them were owned by pharmaceutical manufacturers, because there was one of the early ones was Merck Medco, and before it became Medco. And what happened was the Federal Trade Commission said, we can't have a pharmaceutical manufacturer also involved with distributing medications. So they forced them to forced Merck to divest. And so fast forward into the early 2000s, what happened was that these companies not only were involved in the distribution of medications, but they realized that they could become a choke point, essentially, where they could control what drugs were prescribed, what drugs they would pay for. And they were working with the insurance companies to do this.
And what was the benefit?
The benefit was that they would then create what's called a formulary. And the formulary was constructed based on which drug would pay them the most.
Pay them the most, or they would get the greatest profit, or cost them the least, right?
It's usually driven, at this point, it's driven by profit. Which drugs will generate the most profit for the middleman, the PBM?
So the insurance company at that point is acting as the doctor. So you, as a doctor, prescribe a medication to a patient, you send it into the insurance company, and the insurance company denies your prescription and says, oh, no, that's not on our formulary.
Right. The formulary is the list of drugs that they will cover. And they have different tiers of drugs. They have first-line drugs, first lowest tier, and those are their preferred drugs. And then if a patient fails that, then they may be able to get to the second tier or the third tier. And then they have totally excluded drugs that they won't cover at all.
How is that possible? How is excluding drugs? I've seen where there are specialty medications that aren't covered by insurance contracts. All specialty medications. How is that even allowed?
Well, what you're referring to by excluding all specialty medicines, especially in our field in rheumatology, is that rheumatology drugs, advanced therapies, aren't considered a quote-unquote essential medical benefit. And so the insurance companies actually can exclude them all if they choose to. And that's actually an offshoot of all of this, where there's a scheme or what's called alternative payment models that actually exclude them all. And then basically they have these companies that run these things, and they basically apply to the pharmaceutical manufacturers' uninsured benefits and try to get free drug, and then charge back a percentage of the price of the drug to the insurance company.
So
this is a really sinister offshoot of these what's called alternative payment models, which are now one of the multitude of abuses that are going on in the drug delivery system.
This is racketeering. This is crazy.
Yes.
So the insurance company says that it's not medically necessary, or these specialty medications are not needed for patient care?
So there is something called the essential medical benefit, and that certain classes of drugs have to be included in an insurance product. But biologic therapies for rheumatoid arthritis or for psoriatic arthritis or the diseases we treat, the advanced therapies, are not necessarily part of that essential medical benefit. Now, a company may choose to include that in their services and products that they provide and cover. But it's possible for certain insurance companies to save money, will not include those products and hire one of these alternative payment model purveyors to do exactly what I was just saying.
So I don't understand why it wouldn't be an essential medical benefit. You have people who would be, I guess, living off the dole, right? Having to collect unemployment or Medicaid or not be a functioning member of society because they aren't getting these medications. So why is it allowed to withhold these medications to enable people to live?
That's an excellent question, and it makes absolutely no sense. This is essential for our patients that we see every day to be able to be a productive member of society, to be able to take care of their family, to be able to work rather than become disabled. And so in my opinion, and in many others' opinions, our treatments that are required to manage our inflammatory diseases are essential. There is no question. But the insurance industry has gotten off the hook by having this to be what I would call optional rather than essential.
Are there
or
other
required?
Yeah, are there other medications, oncology drugs, GI drugs, other types of drugs that are as essential as they are in our rheumatology world that are deemed not essential medical benefits?
This goes across. This is not just solely a rheumatology issue. This goes across all of the areas of specialty medicine. It's basically a policy that's set forth by an insurance company of what they will cover and what they won't.
Why is this allowed?
I honestly cannot, for the life of me, understand why, and there are many out there trying to change this so that these abuses, as I've just described, can be cut off.
And you and I are going to be in Tallahassee next week with the Florida Society of Rheumatology. There are only 13 of us actually going this year. I know we open it up, from my recollection, to about 20. Why do you think other people don't get involved?
Well, let me just say that as a practicing rheumatologist in an independent practice, my practice is not owned by private equity. It's not owned by an insurance company. It's not owned by a hospital system. The screws are being put to us.
Mm-hmm.
This is really, we are seeing independent physicians, not just in rheumatology, but in all specialties, especially primary care, become gobbled up by these behemoth medical systems because it's just unworkable.
Do you know 10% of physicians work for United Health Group?
They're the biggest employer of physicians in the country.
I don't think people are aware of that. We just hired a rheumatologist who came from a United Health Group owned hospital in upstate New York. And we just had a conversation about this yesterday. She didn't realize that her group was owned by United Health Group. How crazy is that? So they're actually going under a different guise. I think it's Optum that is owning it, but it's still that one entity of United Health Group.
Yes, they're a subsidiary. I'm not sure what the proper term for them. Optum, but Optum has different branches of services, and they have United Health Group has all sorts of services that they provide under different subsidiaries and branches. So Optum is one of them.
And they are the third most profitable company in America right now.
And guess why they are? Guess where most of their profits come from?
Tell me.
PBM.
Yeah.
PBM services, controlling the flow, controlling the drug supply chain through their PBM services is what creates the vast majority of their profits. And that has to do with them owning their own specialty pharmacy, where they basically try to send all of their patients that are under their insurance, they try to make them go to their own pharmacy so that they can basically get the benefits of that. And they give them preferential profits to their own pharmacy rather than independent pharmacists who are basically drying up and going out of business because they're, in many cases, underwater and can't stay in business with the way things are.
So if I play devil's advocate and I'm the United Health Group CEO and say, well, it benefits patients in the long term because it helps keep the cost of medicine down. It helps keep the cost of healthcare down. If we don't have these checkpoints in place, the premiums will skyrocket and nobody will have health insurance. How do you combat that?
Well, so that's a false statement.
But that's what they're saying.
I think basically what United Health Group does through almost all of the services they provide is they basically are sucking money out of the system that would be much better served to actually apply to providing care, providing treatments, providing medicines, providing diagnostic testing, paying the providers of this service, because they are squeezing us as providers.
So what happens when there are no doctors left? The supply dwindles, the demand increases substantially. What is the long-term plan for United Health Group?
Yeah, I think it's pretty obvious that they just want to basically corner the market in every aspect of medicine. And then they basically can just dictate, put the screws to the patients. They still are, because if you look at what happens to insurance premiums, they just keep going up every year. I see what my insurance premiums are for my Florida Blue insurance. They go up every year. What about what they pay for? Our out-of-pockets keep going up. They keep shifting the payment of services from what they pay to what the patients have to pay for out-of-pocket expense, whether it's a deductible or whether it's co-insurance, and the out-of-pocket maximums that patients are paying is going through the roof. So all of this cost shifting is what is really incredibly profitable for the insurance industry. And then you talk about the drug delivery system, where they basically have schemed to increase their own profits to the detriment of the patients, one, but to the detriment of us who are trying to provide our patients with top-notch medical care.
And I don't want to be so doomsday, because I see these bright-eyed and bushy-tailed students. You teach at USF, so at University of South Florida, and you have students, medical students, coming into your practice. How do we give them optimism? What do you recommend that new grads, new fellowship grads or residency grads who are going into medicine, what do you say to them?
Well, one, we have to teach them medicine and how to practice medicine and how to be a doctor, how to actually take a proper history, do a physical exam, synthesize the information that you get, come up with a possible list of diagnoses, and then how to work it up and then once you make the diagnosis, how to treat them. That's the vast majority of what goes on in medical school, in residency, and in fellowship. And I primarily have fellows rotating through my office. I do have some residents coming through my office. It's rare that I have medical students, but it's incredibly gratifying to see the skill set improve, and I get a tremendous amount of pleasure teaching. I love doing it. It's really a passion.
But Bob, if they can't pay off their student debt because now they're beholden to the insurance company once they actually practice medicine, they're going in very naively and unable to make a living.
So yes, and I think that reality has to be. They need to learn about that too, and so there's a couple of things that we do when the fellows and the residents are rotating through my office. I do talk to them about advocacy, because really what got me into advocacy was that I saw there was this big void that who is going to step up and represent us as medical practices and our patients that we care for.
Mm-hmm.
Who is going to represent us and what we do and what we're passionate about?
Who?
It's got to be us. We have to do it. We have to take ownership of this. Meredith, you do it. You walk the walk.
Yeah, but you and I are
very
very unique in this world.
But we need to teach our folks that we have contact with to how important this is, because we can teach them all the science, and that's what I started with today, was that all these discoveries and amazing drugs and amazing treatments and so on and so forth. But if we can't get access to those treatments because of all the roadblocks, and they just keep increasing, all the roadblocks that are put up there in front of us and in front of our patients, those treatments are no good if the patients can't get them, if they can't afford them, because their out-of-pocket expense is too high, because we can't get them approved, because it's not on formulary. There's all these excuses and all these problems. Who knows better about what our patients need than the patient sitting in front of me, and we're having a conversation about what their goals are and what my goals are, and try to meet in the middle and come up with a plan that's acceptable. What could be better than that? But no, we have Big Brother in the room. They've got this video camera up on the wall, and they're monitoring this. This is hypothetical and kind of an exaggeration, but we make a decision in the office. You are going to get drug XYZ to treat your psoriatic arthritis. And then we put in the request to get that drug paid for. And lo and behold, it comes back, no, you can't have that, because that's not one of our preferred drugs, because we're not getting enough money kickback from the manufacturers to have that one as a preferred drug. You have to use this alternative drug, which may, by the way, for some reason about that patient's own individual health conditions and comorbidities, we call them, may not be the best choice. It may have more safety risks, for example, for that patient. But who's better to do that? Big Brother or me talking to my patient and having a conversation about what's important to them and what I'm looking at to try to control their disease so it doesn't get worse, so it doesn't progress, and the patient doesn't progress towards disability.
I think everybody would agree with you except the insurance company, but it brings me to the point regarding pharmaceutical companies. So they were the ones who used to be blamed left and right, and now we're blaming PBMs. But where do the manufacturers sit in all of this? Why is this still a problem? Are they able to say, no, we're not going to play your game? And could they win that way?
It's possible. But it's possible they could if they all would just walk away from the system as it sits. But there are winners and losers among the pharmaceutical industry. The ones who've paid them off the most, who have their drugs as top tier drugs, they have a huge market advantage. And those companies are the biggest ones. And then there's the others who have chosen, either because of their own financial issues or by their own beliefs, which may be well-founded or may not be well-founded, they are not playing the game as well. And so if your drug is excluded, you can't sell your drug. You can't even give your drug away.
Right. You have to pay to play.
You have to pay to play. It's a kickback system. And that's really what the system is set up. So we need to basically get rid of the kickback system. The kickback system, if you think about it, I mean, yeah, the drug prices have gone up and the blame primarily has been put on the manufacturers. But those manufacturers are under pressure to pay off the middlemen who control the formulary, which drugs are preferred. Who's going to pay them the most? So how do you pay them the most? It's the list price minus a percentage is the net price. And that percentage is what goes to the middleman. And that is the money that is paid from the manufacturer to the PBM for market access. They're paying for market access.
And we don't even get to see these numbers.
No, this is all totally hidden. There's this wall of confidentiality that we can't see it. And, it's only through governmental regulation, essentially, or legislation that there's what's called transparency. And that's part of what we do with ATAP is that's our name, Alliance for Transparent and Affordable Prescriptions. That's what that means. And that's been we've been in business and we've been a coalition since 2017. And that's really what we've been trying to do.
And that's what I want to talk about.
Educate on it, and then promote real fix to the system.
So what's ATAP doing? So it started in 2017. I know you have a lot of different organizations involved in ATAP, and it's your passion project. This is your baby. Share with listeners what your true mission is and how people can get involved to create this change.
Okay, so our mission is to educate, one, on what the PBMs, who are the PBMs, what is their function, how do they function, and why is this causing such market distortion?
Who do you educate?
We educate regulators and legislators primarily. So we've gone to Capitol Hill in DC annually, at least, sometimes twice a year. We've gone to state legislatures to try to educate on what PBMs are, who they are, and what kinds of money they're extracting from the system. It's unbelievable.
What do you think of Sarah Huckabee Sanders and her new rules in Arkansas where an insurance company and a PBM cannot be owned by the same entity?
Boy, what a breath of fresh air.
I know.
That's amazing. She is spearheading amazing PBM reforms, which, by the way, are going to get clogged up in the courts, but because her legislation has passed, and there's been amazing legislation coming out of Arkansas regarding PBM regulation.
Do you think that this is going to spread out throughout the country, or you think it's just going to get stuck in the legal system?
Well, it gets stuck in the legal system after a bill passes, but we have to first get legislation that's meaningful initiated and then passed by the legislature, signed by the governor, and then it takes effect at a certain date. And that's when the legal system and lawsuits will be filed to block it. But we need to get this legislation. All of that needs to happen so that we can move the process. It's not going to happen if there's no legislation and no regulation.
So who's involved with ATAP? You're a past president of the Florida Society of Rheumatology. I know they're involved. You sit on the board with the Coalition of State Rheumatology Organizations. They're involved. Who else encompasses ATAP?
So ATAP is made up by 25 patient and provider organizations. And our organizations include the American College of Rheumatology and the Coalition of State Rheumatology Organizations, national advocacy organizations that are the leaders in rheumatology, in standing up for rheumatology.
Do you have an annual meeting where you all get together and meet? How are you funded? How can somebody get involved who's really revved up by all of the conversation that you and I are having right now.
So other organizations are involved. Many state rheumatology organizations are involved. We actually have, it's not just rheumatologists, though, because we do have a dermatology group that's involved. We do have a urology group that's involved. We have a pain society that's involved. We have patient organizations, the Global Healthy Living Foundation, which is a large patient advocacy organization. We have the Rheumatology Nurses Society. We have the NORM, the National Organization of Rheumatology Office Managers. They're involved. So it's these organizations, and it doesn't have to be just organizations. We've gotten contributions from individuals. We've gotten contributions from county medical societies. I know we're sitting here in South Florida today, and the Palm Beach County Medical Society has contributed in the past. We really appreciate that. Who we don't get money from is individual pharma companies, because they really are a little intimidated because they depend on the PBMs. This is an anti-PBM coalition. So I said we educate, and then we advocate for legislation to actually regulate that, both state and federal.
Do you align with the larger organizations like the American Medical Association or the American College of Physicians? Because the current president of the AMA is very anti-PBM. Have you done any work with them?
We have worked with them in limited capacity, but yes, we have worked. We feel like we're one of the voices. We're not the only voice, but we're an important voice. We've been out there. We've really, I think, moved the needle in terms of education on what these guys do. And then we've also now started to be involved with legislation both at the state and federal level.
A lot of what I hear when I'm meeting with state legislators or I'm meeting with people in Congress on the national side is that they don't see that doctors are aligned. They see that there are so many different groups out there and that we're all asking for something else. Do you see that on your side?
Well, I think on the PBM regulation side, I don't think there's any misalignment or non-alignment among physicians.
Oh, yeah, doctors hate PBMs. But I guess what is the root cause? What do we really need to change to create a better American healthcare system? Because some people want to talk about PBMs. Some people want to talk about electronic health records. Some people want to talk about access to medicine. Some people want to talk about the physician fee schedule. There's so much that it gets muddied.
I don't think it's muddy. I think all of these issues are hugely important.
But if we don't target, that's what my concern is. If we don't target, and I'm not making this up, you and I go to some of the same meetings and we hear from the politicians that I'm getting feedback from so many different organizations and different angles. Can we focus so we know what we need to do to help you?
Unfortunately, there are so many fires, and these are 5-alarm fires, that are facing us, especially us in private practice, that we need all sorts of reforms, because what's happening is the opposition keeps coming out with more and more draconian edicts that are absolutely affecting our ability to practice medicine and do the best we can for our patients, and also stay in business. We are, at the end of the day, a business. My practice employs 25 people. And I'm telling you, it's harder and harder year after year to actually keep the door open. And if you aren't now really on top of your organization in terms of the business of your organization, you will not make it and you will go under.
So it's a Friday today, and you are at least 3 hours from Clearwater where you practice. And next week, you're going to be in Tallahassee with me for 2 work days. How do you juggle running an independent practice and making sure that you cover payroll for these 25 individuals and do all of the advocacy work that you do?
So that's a great question. And I've just made it a priority for me personally to be involved because, there's an old adage that's probably everybody's heard it. But if you don't have a seat at the table, you're on the menu.
Mm-hmm.
And if we don't represent us as rheumatology practices and as medical practices, and we're not up there representing what's good medical care for our patients, who is going to? It's not going to be the insurance companies, because it's not going to be the PBMs in terms of what we face in medical practice. So honestly, I have made that a priority, and it's critically important that we have passionate people who understand the issues that can go up and basically explain why certain things that are done and certain practices that are currently being done to us and to our patients should be either outlawed or regulated. There's just such a long list.
So with that long list, because I'm going to wrap up and ask you the same question I ask every single guest, but there are so many items that we want to fix. If you could create just one change within our American healthcare system, what's the most vital?
Ooh, that's a tough one.
I know. I ask everybody.
Because it's a tough one, because we're faced with so many. So I'm passionate about PBM reform and access to care, access to treatment. And I think there are some tangible changes that can be made to improve things on that front. I'll just mention one. And that is actually in the Senate finance bill that was just dropped yesterday.
Mm-hmm.
That looks like it might have some legs because it's got lots of bipartisan co-sponsors in the Senate. But delinking, which basically means that the PBM compensation for the service rendered is not linked to the list price of the drug, that they're not getting a percentage of the list price of the drug, which creates that system, which is in place now, creates a perverse incentive for the PBM to pick preferred drugs that are more expensive because then they get more money. So if we delink that and we give them a flat fee, a fair market value flat fee, then what will happen is that there's no incentive for them to pick the more expensive drug. And guess what? Our patients are paying a percentage off the list price. So lower list price means lower out-of-pocket expense for the patients, which makes drugs much more accessible. So if I was to pick one, just because of the space that I'm in, I would pick that. But there are so many others that need to be fixed. Like I said, 5-alarm fire.
Dr. Robert Levin, thank you for being on Working Healthcare, my friend and my advocacy champion.
Thank you so much, and it's been such a pleasure to be here.
If this conversation hit home or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post about it on social media. Connect with me on LinkedIn to keep the conversation going in between episodes. If you've got a question, an episode idea, or someone you think I should feature, send me a note at meredithhirsch.com. Thank you all for the 5-star reviews. They help more listeners find the show. New episodes drop every Tuesday. Subscribe so you don't miss what's next. Tune in weekly as we explore the inner workings of healthcare, because you can't fix what you don't understand.